Hey, what's up guys? Today we're going over what you need to know about neutropenia. So neutrophils are the main type of white blood cells in your body. They're the cells responsible for phagocytosing, basically eating the pathogenic microbes when they enter your body. They are your body's first responders. When neutrophils drop, we call that neutropenia. So let's talk about numbers, and this is something you need to memorize. So in clinical practice, we use the absolute neutrophil count or ANC as our benchmark. The normal absolute neutrophil count ranges from 3,000 to 7,000 cells per microliter. To calculate the ANC, multiply the total white blood cell count by the neutrophil percentage, including SAGs and BANs. And here's what those numbers mean clinically. An ANC of 500 to 1,000 cells per microliter indicates a moderate risk of bacterial infection, and an ANC under 500 cells per microliter indicates severe neutropenia and a high risk. So for example, if a patient has a white blood cell count of 6,000 cells per microliter, segmented neutrophils of 60%, and BANs of 5%, using the ANC formula, you'll end up with an ANC of 4,225 cells per microliter, which is considered normal. And one thing to note about neutropenia is when the neutrophils count fall rapidly, the body's immune defenses can be overwhelmed before any compensatory or protective mechanisms can adapt. A sudden steep decline leaves virtually no window for clinical interventions, such as giving antibiotics before the patient becomes dangerously sick. In contrast, a gradual decline may allow us some time for monitoring and early intervention. And here are the common organisms to know that help guide antibiotic therapy. So what actually causes neutropenia? There are broad several categories. The most common cause is chemotherapy and immunosuppressive therapy. So chemo drug like methotrexate can suppress bone marrow activity, reducing neutrophil production while treating cancer. So there's a term called nadir, which is the lowest point of blood cell counts during chemotherapy, and it is when the patients are most vulnerable. Other causes include infections, severe sepsis, and fulminant bacterial infections can themselves deplete neutrophils. Autoimmune conditions or diseases like lupus can cause immune system to attack its own neutrophils. And other risk factors that worsen outcomes include being over age of 60, having immune disorders or taking steroids, and having an existing or prior fungal infection. So neutropenic patients are vulnerable to opportunistic pathogens, even organisms from their normal body flora. And here's the critical part. The classic signs of infection may be absent. So no white blood cell mean no pus. So no redness, heat, or swelling. So what do you look for? Common signs and symptoms you look for are sore throat or difficulty swallowing, ulcer lesions in the mouth or throat, diarrhea or rectal tenderness, vaginal itching or discharge, shortness of breath, and even non-productive cough. And the most important symptom to recognize is neutropenic fever. Neutropenic fever is defined as temperature of a greater than or equal to 100.4 Fahrenheit, new symptoms suggesting infection, and with an ANC of less than 500 per microliter. Neutropenic fever is considered medical emergency. And here's your timeline. Blood cultures must be drawn within 1 hour, and antibiotics must be administered within 1 hour as well. Do not wait, do not watch and see. A low-grade fever in neutropenic patient can spiral to septic shock, and that within hours. So how do we confirm neutropenia? Here's the diagnostic workup. Peripheral white blood cell count to check the total white blood cell count. Differential count to confirm ANC less than 1,000 per microliter. Peripheral blood smear to look for immature white blood cell forms or BANs. Hematocrit, reticulocyte count, platelet count to assess overall bone marrow function, and bone marrow aspiration and biopsy to examine cell numbers and morphology when cause is unknown. Management comes down to 4 key pillars. First, determine the cause. Is this a chemo-induced, nutritional, drug-related? The answer shapes your plan. Identify and treat infection. Obtain 2 sets of blood cultures and start broad-spectrum IV antibiotics within 1 hour. Monitor continuously, vital signs every 15 minutes to 1 hour. Assess mental status. Ongoing fever or change in assessment warrants new cultures and possible escalation of therapy. Protective practices. Hand hygiene is the single most important protective measure. You should use antiseptic wash or gel before and after every contact. Neutropenic patients must also be placed in a private room with HEPA filtration. For dietary education, avoid raw or undercooked meats and eggs. Wash fruits and vegetables thoroughly. And myeloid growth factors like GCSF can be used prophylactically to prevent neutropenia or reduce its severity. But once neutropenia has already developed, they're generally less effective. Alright, let's wrap up. Here are your takeaways.